mesencephalon or the hindbrain. Simultaneously, it forms two flexures, the cervical flexure at the junction of the hindbrain and spinal cord, and the cephalic flexure in the midbrain. Two parts of proencephalon are the telencephalon and diencephalon. Two parts of the rhombencephalon are the mesencephalon, which later forms the pons and cerebellum and the myelencephalon. Cavities of the brain vesicles, the rhombencephalon, it is located in the fourth ventricle, the encephalon, third ventricle, cerebral hemispheres, the lateral ventricles. The lumen of the mesencephalon connects to the third and fourth ventricles known as aqueduct of Sylvius.
Normal yan siya.
The neuroepithelial layer is a thick pseudostratified epithelium located at the wall of the newly closed neural tube. The mantle layer consists of primitive nerve cell. This later forms gray matter of the spinal cord. The marginal layer, outermost layer, nerve fibers emerging from the neuroblast in the mantle layer, and then will form as a white matter of the spinal cord. Histologic differentiation of nerves. The neuroblasts are non-dividing cells that arise exclusively by division of the neuroepithelial cells. Initially, they have a transient dendrite extending to the lumen, but when they migrate into the mantle, the process disappears and neuroblast temporarily round and apolar. Letter A, the apolar one. The apolar neuroblast, the bipolar neuroblast, and the multipolar neurons. Axons of neurons in the basal plate break through the marginal zone and become visible in the ventral aspect of the cord. It is known collectively as the ventral motor root of the spinal nerve. Conduct impulses from the spinal cord to the muscles. Axons in the dorsal sensory horn, alar plate, behave differently from those in the ventral horn. Next. The glial cells, majority of the primitive supporting cells, the glioblasts, are formed by neuroepithelial cells after production of neuroblast ceases. Next, please. Next, please. Thanks. The neural crest cells. During elevation of neural plate, a group of cells appears along each edge, the crest of the neural folds. Crest cells migrate laterally and give rise to sensory ganglia of the spinal nerves and other cell types like sympathetic neuroblast, Schwann cells, pigment cells, odontoblasts, meninges, and mesenchyme of the pharyngeal arch.
The spinal cord, positional changes of the cord. In the third month of development, the spinal cord extends the entire length of the embryo, and spinal nerve pass through the intervertebral foramina and their level of origin. With increasing age, the vertebral column and dura lengthen more rapidly than the neural tube. Next, please. At birth, this ends at the level of the third lumbar vertebra. As a result of this hello. As a result of this disproportionate growth, spinal nerves run obliquely from their segment of origin in the spinal cord to the corresponding vertebral column. Next, please. In the adult, the spinal cord terminates at the level of L2 to L3. The dural sac and subarachnoid space extend to S2 to the coccyx, and it is called the coccygeal ligament. Below L2 and L3, a thread-like extension of the pia mater forms the filium terminale, which is attached to the periosteum of the coccygeal vertebra and which marks the track of regression. Next. So the brain, rhombencephalon hindbrain, is a distinct basal and alar plates representing motor and sensory areas. Consist of the myelencephalon, the most caudal of the brain vesicle, and the metencephalon, which extends from the pontine flexure to the rhombencephalic isthmus.
So mesencephalon or midbrain serves important function in movement, particular movements of the eye and in auditory and visual process. So it is located in junction between in both middle and posterior cranial fossa. So each basal plate contains two groups of motor nuclei, the medial somatic efferent group and small general visceral efferent group. So the medial somatic efferent group represents the oculomotor and trochlear nerves which innervate the eye musculature, while the small general visceral efferent group represents the nuclear of Edinger-Westphal which innervates the sphincter pupillary muscle. So the mesencephalon is divided into parts. So the anterior part is the crus cerebri and the posterior part is the tegmentum. So the crus cerebri is the anterior portion of the cerebral peduncle which contains the motor tracts traveling from the cerebral cortex to the pons and spine. The plural of which is the cerebral crura. It forms the majority of the base of the pedunculi in the midbrain. So it also serves as a pathway for nerve fibers descending from the cerebral cortex to the lower centers in the pons and spinal cord. The cerebri are superficially corrugated and emerge from the cerebral hemisphere. They converge as they descend and meet as they enter the pons, where they form and caudolateral boundaries and interpeduncular fossa. Another part of is the prosencephalon or the forebrain. The prosencephalon consists of telencephalon and diencephalon. So diencephalon is a division of the forebrain, or other term is embryonic prosencephalon, and is situated between the telencephalon and the midbrain or the embryonic mesencephalon. The telencephalon forms the cerebral hemisphere. And then the diencephalon forms the optic cup and stalk and pituitary, thalamus, hypothalamus, and epiphysis. So the groove is formed by the thin. Next slide, please. So the diencephalon has roof plate and the epiphysis. So the roof is formed from the thin tela choroidea, which is a combination of two membranes, the epidyma and the pia mater. Within the tela choroidea are two plexus of blood vessels that bulge downwards in the cavity of the third ventricle. So these are the choroid plexuses of the third ventricles, which functions as a point of production of the CSF. So the roof plate of the diencephalon consists of a single layer of ependymal cells covered by vascular mesenchymal. So that is where the spinal fluid is produced. So the most caudal part of the roof plate develops into the pineal body or the epiphysis, and the body initially appears as an epithelial thickening in the midline, but by the 7th week it begins to invaginate. The calcium is frequently deposited in the epiphysis and serve as a landmark on radiographs of the skull. Next slide, please. So this is the roof plate of the encephalon. Next slide. So the diencephalon has hypophysis or pituitary gland, and then the hypophysis or pituitary gland develops from the two completely different parts: the ectodermal outpocketing or the wrap pouch and the infundibulum. So basically, the hypophysis or pituitary gland has two different parts. One is the rat pouch and the infundibulum. So the rat pouch increase rapidly in number and form of anterior lobe of the hypophysis or adenohypophysis. And then another part is the pars tuberalis. It is a part of the anterior lobe of the pituitary gland and wraps the pituitary stalk in a highly vascularized sheath. So it goes along the stalk of infundibulum and eventually surrounds it. So yun na nga. The posterior wall of the rat pouch develops into the pars intermedia, which is in humans seems to have little significance. And then the infundibulum gives rise to the stalk and the pars nervosa, or the posterior lobe of the neurohypophysis. It is composed of neuroglial cells, and in addition to it, it contains a number of nerve fibers from the hypothalamic area. Next slide, please. So the telencephalon consists of cerebral hemispheres that are continuous growth of the cerebral hemispheres in anterior, dorsal, and inferior directions, result in the formation of frontal, temporal, and occipital lobes respectively. So the area between the frontal and temporal lobes becomes depressed and is known as the insula. So this region is later overgrown by the adjacent lobes, and at the time of birth is almost completely covered. So during the final part of the fetal life, the surface of the cerebral hemispheres grows so rapidly that a great gyre separated by the fissures and sulci appear on its surface. Next slide. So the cortex development of the cerebral cortex develops from the pallium, which has two regions, the palliopallium and the neopallium. So in neopallium, it is lateral to the corpus striatum, and the neopallium is just between the hippocampus and the pallium. In the neopallium, waves of the neuroblasts migrate to a subial position and then differentiate into fully mature neurons. And then at birth, the cortex has a stratified appearance due to differentiation of the cells in the layers. So mostly the motor cortex contains a large number of pyramidal cells, and the sensory areas are characterized by granular cells. Next slide, please. So it also has the olfactory bulbs and commissures. So the differentiation of the olfactory system is dependent on the epithelial mesenchymal interaction. So these occur between neural crest cells and the ectoderm of the front nasal prominence to form the olfactory placodes, and between these same crest cells and the flora of the telencephalon to form the olfactory bulbs. So cells in the nasal placodes differentiate into primary sensory neurons of the nasal epithelium, and then it grows and make contact with the secondary neuron of the developing olfactory bulbs. So by the 7th week, this contacts and growth in the brain continues. The olfactory bulbs and the olfactory tracts of the secondary neuron lengthens, and together they constitute the olfactory nerve. So the commissures are the cross the midline, connects the right and left halves of the hemisphere. So basically, it is the most important fiber bundles that makes you of the lamina terminalis. The first of the crossing bundles to appear in this is the anterior commissure. So the commissure has three, what do you call this one? Has three bundles. So it is the first bundle of the crossing bundles, or the anterior, the secondary, and the next slide, please.
According to Dr. Rada, let's proceed na to the anomalies. Yung pag-report po. Thank you.
So hypophyseal defects, the rat pouch, remnant, and pharyngeal hypophysis are these are the pituitary that begins its development as a pouch which forms in the roots of the pharynx. So it's the rat pouch. This tissue must migrate to the site of the developing hypothalamus. So in humans, this migration does not always occur flawlessly. In some individuals, pituitary tissue remains in the roof of the pharynx as the pharyngeal hypophysis. Next slide. So craniopharyngiomas, this arise from the remnants of the rat pouch. This may form within the sella turcica at along the stalk of the pituitary, but usually lie above the sella. They may cause hydrocephalus and pituitary dysfunction. So like this example, diabetes insipidus and growth failure. Another cranial defect is the holoprosencephaly, or HPE. It is a spectrum of abnormalities in which a loss of midline structures results in malformation of the brain and the face and the face. So the cause is attributed to the mutation of the SHH, or the sonic hedgehog gene. The gene regulates the establishment of the ventral midline in the central nervous system. So many of the defects, including those of the limbs and brains, may be due to abnormal sonic hedgehog gene, signaling as cholesterol is necessary for this gene to exert its effect. Next slide. Other genetic causes, including mutation in transcription factors like Cynoculi 6-3, TGIF, and the zinc finger protein. And then the non-genetic predisposing factors of holoprosencephaly includes alcohol abuse. So basically, mothers who consume alcohol during their pregnancy, then which are early stage of development of midline cells. So the severity of the facial anomalies tend to correlate with the severity of the cerebral lesions. The face predicts the brain. So it is classified into three main subtypes based on upon the severity of the malformation. So number one is the alobar holoprosencephaly. So it is a complete failure of the brain to divide into right and left hemispheres, which result in the loss of midline structures of the brain and face, as well as fusion of the cavities of the brain, known as lateral ventricles and the third ventricle, which are normally separated. Next slide. Another is the semilobar holoprosencephaly, which occurs from the left side of the brain. So it's fused to the right side of the area of the brain, known as the frontal and parietal lobes. Also divide the line between the right and left hemispheres of the brain. Is only present in the back of the brain. And then another is the lobar holoprosencephaly, which is when there are two ventricles, the right and the left, but the cerebral hemispheres are fused in the frontal cortex. And then the fourth one is the middle interhemispheric variant, which results when the brain is fused in the middle. individual. So signs may include closed space eyes, depressed and narrow nose, or an almost normal looking face. So basically, it is hard to, slightly hard to distinguish this kind of, Next slide. So Smith-Lemli-Optic syndrome, also referred to as the HCR7 abnormality or RH syndrome, a variable genetic disorder that is characterized by slow growth before and after birth, small head or microcephaly, mild to moderate mental retardation, and multiple birth defects, including particular facial features, cleft palate, heart defects, fused second and third toes, extra fingers and toes, and underdeveloped external genitals in the males. So males are mostly affected in this kind of abnormality. The SLOS is caused by a deficiency in the enzyme 7-dehydrocholesterol reductase, which metabolizes 7-dehydrocholesterol to cholesterol. The SLOS is inherited as an autosomal recessive genetic disorder. The enzyme deficiency occurs as a result of abnormal DHCR7 gene inherited from each parent. So basically, only the males are, mostly the males are affected with this kind of abnormality. Next slide. So schizencephaly, it is an extreme rare development birth defect characterized by abnormal slits or clefts in the cerebral hemispheres of the brain. So you can see this in MRIs that there will be what do you call this one? Slits or clefts in the brain. But next slide, please. So symptoms of schizencephaly is developmental delays, seizures, abnormally small head, so microcephaly, intellectual disability, because if you have microcephaly, of course, the brain development is also halted. And then partial or complete paralysis, poor muscle tone or hypotonia, and hydrocephalus. So causes, the exact cause of schizencephaly is unknown. A small number of people with schizencephaly are found to have changes in mutations in, example, EMX2 and etc. Rarely, schizencephaly can affect more than one family member, and then this supports a genetic cause in some cases. Next slide. So ossification defects, so these are defects of the bone or problems in the osteogenesis in the bone remodeling in the process of laying down new bone material by cells.
Hello, Doc. Can you hear me? Exencephaly. See, okay, next slide, please. Hello? Yes. Definition. Type of cephalic anomaly. The brain is outside of the skull. Failure of the cephalic part of the neural tube to close. The vault of the skull does not form, leaving the malformed brain exposed. Next slide, please. Facial structures and skull base are preserved. Residual brain tissue is present and floats in amniotic fluid. Causes caused by the failure of the cranial neuropore to properly fuse between the third and fourth week post-conception. The calvarium doesn't develop fused properly, therefore the brain extrudes from the cranium. Next slide, please. Hello? Hello? Symptoms. Sonographic findings in the first trimester include absent calcification of the cranial bones, lateral widening of the cerebral hemispheres, or the Mickey Mouse sign, and echogenic amniotic fluid. In the second trimester, a significant amount of brain tissue is lost, resulting in the frog face sign due to an absence of recognizable tissue superior to the level of the fetal orbits. Hydrocephalus. Hydrocephalus is usually due to blockage of CSF outflow in the ventricles or in the subarachnoid space over the brain. Alternatively, the condition may result from an overproduction of the CSF, from a congenital malformation blocking normal drainage of the fluid, or from complications of head injuries or infections. Hydrocephalus as seen on a CT scan of the brain. The black areas in the middle of the brain or the lateral ventricles are abnormally large and filled with fluid. A 1-year-old girl with hydrocephalus showing sunset eyes. Causes. Congenital hydrocephalus is present in the infant prior to birth, meaning the fetus developed hydrocephalus in utero during fetal development. Aqueductal stenosis is most common. Narrow passage between the third and fourth ventricles in the brain is blocked or too narrow to allow sufficient cerebral spinal fluid to drain. Fluid accumulates in the upper ventricles, causing hydrocephalus. The causes are usually genetic but can also be acquired and usually occur within the first few months of life, which include intraventricular matrix hemorrhages in premature infants and infections. About 80 to 90% of fetuses or newborn infants with spina bifida often associated with meningococcal or myelomeningococcal develop hydrocephalus. Acquired hydrocephalus, this condition is acquired as a consequence of CNS infections, meningitis, brain tumors, head trauma, toxoplasmosis, or intracranial hemorrhage, or subarachnoid or intraparenchymal, and usually painful. Symptoms. In infants with hydrocephalus, CSF builds up in the central nervous system, causing the fontanelle or soft spot to bulge and the head to be larger than expected. Early symptoms: eyes that appear to gaze downward, irritability, seizures, separated sutures, sleepiness, and vomiting. Symptoms that may occur in older children can include brief, shrill, high-pitched cry, changes in personality, memory, or the ability to reason or think, changes in facial appearance and eye spacing, or craniofacial disproportion. Symptoms: delayed milestones, failure to thrive, slow or restricted movement, crossed eyes or uncontrolled eye movement, vomiting. Okay. Difficulty feeding, excessive sleepiness, headaches, irritability, poor temper control. Next slide.
Microcephaly. So microcephaly is a condition where a baby's head is much smaller than expected. So we have two different types of microcephaly that are recognized. We have primary and secondary. Next slide, please. So primary microcephaly, it occurs when the brain does not grow in normal size in utero while the secondary microcephaly, it occurs and after birth. So microcephaly can be also an isolated condition, meaning that it can occur with no other major defects or it can occur in combination. Next, please. Slide. The signs and symptoms, the main feature of microcephaly, it's a head size that is much smaller than normal, and other signs may include poor weight gain and growth, poor appetite or feeding, muscle tone, speech delays, mild to severe learning disabilities. Next, please. Next slide, please. Next slide, please. Microcephaly can also be accompanied by other medical problems such as very short stature. So causes for microcephaly has a variety of causes. Some forms are linked with severe. So the causes for primary microcephaly includes the cytomegalovirus, the rubella, the toxoplasmosis, the varicella, Zika virus, genetics, and diet. Next, please. Causes for secondary microcephaly includes brain infection, traumatic brain injury, oxygen deprivation in the brain, and certain metabolic disorders such as Rett syndrome. Next, please. So in diagnosing microcephaly, it can be diagnosed during pregnancy or after the baby is born. So during pregnancy, we can use the ultrasound test. It is done late second trimester or early in the third trimester. And after the baby is born, we can diagnose microcephaly having a measurement for the head circumference during physical exam. Next slide, please. And other CNS disability, we have intellectual disability or ID. It's once called the mental retardation. It is characterized having below average intelligence, which is around below 70 to 75 IQ. Next, please. Next slide, please. Okay, someone with intellectual disability has limitations into can be intellectual functioning and adaptive behaviors. For intellectual functioning, it includes or refers to person's ability to the IQ or intelligence quotient is measured by an IQ test. So a person is considered intellectually disabled if he or she has an IQ of less than 70 or 275 IQ. Next slide, please. So to measure a child's adaptive behavior, a specialist will observe the child's skills and compare them to other children. Things such as how well the child can feed or dress himself, how well the child is able to communicate with others and understand with family, friends, and other children of the same age. Next slide. So we have different types of intellectual disabilities. We have Fragile X syndrome, the Down syndrome, the Prader-Willi syndrome, and the fetal alcohol spectrum disorder. Next slide, please. Okay, we have the Fragile X syndrome. It is the most common known cause of inherited intellectual disability. It's a genetic condition caused by a mutation in the X chromosome. Next slide, please. Here, the Down syndrome, it is a genetic disorder which occurs in someone is born with a full or extra copy of chromosome 21 in their DNA. Next slide, please. We have the Prader-Willi syndrome. It's also a rare genetic disorder that affects around 1 in 10,000 to 20,000 people. Disability is quite complex and is caused by an abnormality in the genes of chromosome 15. Next slide, please. For the fetal alcohol spectrum disorder, this refers to a number of conditions that are caused when an unborn fetus is exposed to alcohol. Next slide, please. So the signs of symptoms, we have rolling over, talking late, slow to master things, difficulty remembering things, behavioral problems such as explosive tantrums, difficulty with problem solving or logical thinking. Next slide, please. Next slide, please. Okay, the most common causes of intellectual disability are genetic conditions such as Down syndrome, Fragile X syndrome, the Prader-Willi syndrome, the problems during pregnancy that interfere with fetal brain development such as alcohol, or drug use, or malnutrition, or certain infections. Next slide, please. So, other cause for intellectual disability, we have problems during childbirth. It may result if a baby is deprived of oxygen during childbirth or born extremely premature, or illness or injury, infections like meningitis, whooping cough, or the measles can lead to intellectual disability. Next slide, please. So the causes of none of the above, about 2/3 of all children who have intellectual disability have the cause is unknown. Next slide, please. Okay, to diagnose, we have three things factor in diagnosing intellectual disability. First, we have to interview the parents, we have to observe the child, and testing their intelligence and adaptive behavior. And if a child is considered intellectually able if he or she has deficits in both IQ and adaptive behaviors, but if only one or the other is present, the child is not considered intellectually disabled. Thank you.
We'll now move on to the abnormalities of hair distribution. Next slide, please. So we're going to talk about two abnormalities of hair distribution, which is the hypertrichosis and atrichia. Next slide, please. So hypertrichosis is caused by an unusual abundance of hair follicles. Its etiology is the mutation of an autosomal dominant gene resulting in the dysfunction of proteins involved in the development of hair follicles. Next slide, please. It may be localized to certain areas of the body, especially the lower region, covering the spina bifida occulta defect, or may cover the entire body. Next slide, please. So this is where the may cover the whole body or the spina bifida occulta defect localized. Next slide, please. So there are three types of congenital generalized hypertrichosis. The first one is the congenital hypertrichosis lanuginose, which covers the entire body surface except for the palms, soles, dorsal hands and feet, and prepuce are covered with fine silver gray to blonde lanugo hair. This gives off a werewolf appearance. Next slide, please. The second type is the universal hypertrichosis, which presents a thick long hair on the back, proximal extremities, and preauricular areas, often thought as exaggerated normal hairiness. Next slide, please. And the next one is the hypertrichosis universalis congenita, also known as the Abra syndrome. Presents with fine silky light colored long hair primarily involving the face, ears, shoulders, and nose, associated with minor facial dysmorphism, supernumerary nipples, and dental anomalies. Next, please. So the localized areas of hypertrichosis may be signs of defect underlying the patch of hair, which is the fawn tail sign and the hair color sign. And fawn tail sign is a patch over the lumbosacral area signifying the presence of spina bifida occulta or diastematomylia. And the in hair color sign is a ring of hypertrichosis that surrounds the aplasia cutis or ectopic brain tissue. Next slide, please. So this is what it looks like. Next slide, please. So an atrichia is the congenital absence of hair, usually associated with abnormalities of other ectodermal derivatives, teeth, and nails. It is caused by the mutation of a human hairless gene on chromosome 8p21 to 22. And next slide, please. So the types of atrichia is atrichia congenita without ectodermal defects isolated form. It's a rare autosomal recessive condition characterized by the shedding of scalp hair 6 months of age, after which no hair occurs. Eyebrow lashes, eyelashes, and body hair may also be sparse or absent. Patients may have a few pubic or axillary hairs. Okay, next slide, please. An atrichia with papular lesions, it is a rare autosomal recessive disease characterized by early onset of atrichia followed by a papular eruption. It is observed in patients with dietary vitamin D deficiency or in patients with vitamin D dependent rickets type 1 or who have 25 hydroxyvitamin D1 alpha hydroxylase deficiency. Next slide, please. We now move on to the mammary gland abnormalities. Specifically, we will be talking about the polyphelia, polymorphia, and the inverted nipple. Next slide, please. So the etiology of polyphelia and polymorphia is the failure of normal apoptotic regression of the mammary ridges during gestation. Next slide, please. In polyphelia, condition in which accessory nipples have formed resulting from a persistence of fragments of the mammary line, and accessory nipples may develop anywhere along the original mammary line, usually appear in the axillary region. Considered a benign congenital anomaly and serves as a potential important marker for malformations and malignancies. Next slide, please. So this is what a polyphelia may look like. Okay, next slide. While in polymorphia occurs when a remnant of the mammary line develops into a complete breast. Next slide. So if in polyphelia it is an accessory nipple, in polymorphia it's a complete breast. Next slide, please. Next is the inverted nipple, condition in which the lactiferous ducts open into the original epithelial pit that has failed to revert. Next slide, please. So in normal nipple development in utero is seen around the third trimester, wherein the mammary pit develops into the at the epidermis of the mammary. But during the 9th month, this pit undergoes canalization and underlying mesoderm proliferates to raise it above the level of the areola, leading to a formation of a nipple. So in inverted nipple can be of the developmental patterns, and the mesoderm failed to rise the nipple above the areolar plane. Next, please. So
Oh. Okay, so let's proceed to melanocyte function disorder. Next slide, please. Hello, nababatian ako.
Melanocyte function disorder.
Ano ba't na-report? Dili, may ambot.
Melanocyte function disorder or pigmentary disorder. Next slide, please. Melanocytes are melanin-producing neural crest-derived cells located at the bottom layer or the stratum basal of the skin, epidermis, the middle layer of the eye or the ovea, the inner ear, vaginal epithelium, meninges, bones, and heart. Next slide, please. So this location, yung sa baba po, that's the melanocytes, the basal area. Next slide, please. So this is the microscopic image of melanocyte. That one po, yung nasa arrow. Next slide, please. Pigmentary disorders. First is the Pielbaldism, condition characterized by the absence of melanocyte in certain areas of the skin and hair, or the patchy absence of hair pigmentation. Second is the Widenbridge Syndrome. It features patches of white skin and hair. So here are some common characteristics of Widenbridge Syndrome. First is the forelock and then the heterochromia iridis. So the forelock is a piece of hair that grows or falls over the forehead. It's the part of the eye, part of the face above the eyes. Then heterochromia iridis is the eyes of different colors, white patches of skin, and deafness. So the absence of melanocytes derived from these cells in the stria vascularis in the cochlea accounts for deafness in these diseases. So this patient is exhibiting heterochromia iridis. So magkaiba yung kulay ng eyes niya. Next slide, please. Patient with Warden syndrome, so the forelock. Next slide, please. Disease of melanocyte function, albinism and vitiligo. So let's discuss first the albinism. So albinism is a genetic disorder characterized by globally reduced or absent pigmentation of the skin, hair, and eyes. Next slide, please. So this patient is exhibiting albinism. So let's proceed po sa vitiligo na po with Doc Casano. Treatment. So treatment, since albinism is a genetic disorder, it cannot be cured. So treatment focuses on getting proper eye care and monitoring skin for signs of abnormalities. Your care team may involve your primary care doctor and doctors specializing in eye, the ophthalmologist, and the dermatologist for the skin care. Thank you po. Hello.
So vitiligo, nababatian ako, is a disease that causes loss of skin color in patches. Next slide, please. So symptoms is patchy loss of skin color, which usually first appears on the hands, face, and areas around the body openings and the genitals. Premature whitening or graying of the hair on your scalp, eyelashes, eyebrows, or beard, and then loss of color in the tissues that line the inside of your mouth and nose. Next slide, please. So there are types of vitiligo. The universal vitiligo is nearly all skin surface. Generalized vitiligo affects many parts of your body. Segmental vitiligo, only one side or part of your body. Then the localized or focal vitiligo, one or only a few areas of your body. And then the acrofocal vitiligo is the face affectation on the face and hands. Vitiligo can start at any age, but usually appears before the age of 30. Next slide. So causes of vitiligo, it occurs when pigment-producing cells or the melanocytes die or stop producing melanin. It's unclear exactly what causes these pigment cells to die, but it may be related to autoimmune condition, family history, and trigger event. Next slide. So treatment, there is no permanent cure for vitiligo at time. Patches disappear on their own. Otherwise, doctors can prescribe treatments that might help even out skin type. Example is sunscreen, concealers, corticosteroid creams, photochemotherapy, and narrowband. So the PUV is nagamit combination ito yahin medicine which gintetake nimo or pwede ya butang skin topically which is the Soralen. Tapos gini-expose ka ha long wave nga long wavelength. Tapos it difference ito ni ha UV same hera gin-expose sa wavelength pero it UVA is long and UVB is short. Tapos the purpose of this therapy is to increase the number of melanocyte in areas affected by vitiligo and prevent new patches from forming. Next slide, please. Oh, internet akon. Oh, sige.
We'll now
Keratin is
move on to the keratinization disorders. So this refers to a large and heterogeneous group of dysrenification, which the majority are genetically determined. The major symptom of this is generalized scaling of skin with flat redness, which also affects some organs. Next slide, please. So the majority of ichthyosis are rare diseases due to mutations of one single gene. They are transmitted in an autosomal dominant recessive or recessive X-linked manner. Next slide, please. Okay. So one example of this is the collodion baby, which applies to newborns who appear to have an extra layer of skin, also known as the collodion membrane. The appearance is often described as a shiny film looking, and the eyelids and mouth have the appearance of being forced tightness. This is an example of a collodion baby. Next slide, please. Another type of example is the Harlequin Iphiosis, which is a severe genetic disorder that mainly affects the skin. The newborn infant is covered with plates of thick skin that crack and split apart. The thick plates can blur facial features and can restrict breathing and mutations. And eating pala, sorry. Next slide. I don't know.
Excuse me, Doc. We're done na po.
Doc, you're on mute po ata.
Hello, can you hear me?
Yes
Hello?
po, Doc.
Okay,
Yes po.
sorry. Earlier in the reporting, napansin ko na you were going into the details of the central nervous system. So, I said na baka hindi nyo matapos yung reporting. So, I texted na go direct to the anomaly. On the anatomy, neuroanatomy, sa ano nyo, sa libro nyo. So, what I wanted is for you to understand each of the anomalies that are presented, ha? Para hindi nyo makalimutan. Do you understand kung bakit didiretso tayo sa anomalies, ha? So, and you will meet all of this again when you go to pediatric surgery or you go to obstetrics and gynecology and pediatrics. So, at least malalaman nyo. Now, and for those who want, can you still hear me? Can you hear me?
Yes po, Doc.
Yes, Doc.
Yung iba na gusto maging maging dermatologist. Oh, walang gusto maging derma. So, I guess when you go to third year and fourth year, you will like or you would want to become a dermatologist. Ito, start pa lang ito ng how you will be introduced to the diseases of the skin. Kasi yun talaga ang imamaster nyo when you want to become a dermatologist. So, I just want to let you know na yung anak ko is a doctor and she's a dermatologist. So, tatlo pa lang sila dito na fellow and diplomate. So, I guess by the time you will go into residency training and specialization, magiging derma din kayo. So, i-master nyo na ngayon, ha? Pag mayroon kayong, for example, may mga lessons kayo ngayon, don't just sit on it. After this, magbasa kayo para ma-remember nyo kung ano kaya ang what are the diseases of the skin na ngayon, di ba? Ano ba yung Harlequin? Ano ba yun? And then yung difference between vitiligo and your albinism, di ba? So you should know the difference. So you have to question kung ano talaga, ha? Para ma-remember nyo. Okay? So the next reporter will be on, ano ba yon? What's the next report? Dali, ha? So the next report will be on, ano ba yun? Basta the leader is Santos Noel. Where are you, Santos? Mr. Santos. Are you in? Santos Noel? Anong report nyo next time?
Good afternoon po, Doc.
Yes.
Doc, yung next topic po namin, yung topic po namin is axial and musculoskeletal po. Okay, so you can touch a little bit on the generalities about the musculoskeletal system. Yeah, musculoskeletal lang kasi ito. So you can touch a little bit, let's say 5 to 10 minutes of the basics, and then you go directly to the anomalies, ha? Para ma-remember nyo, okay? So I want you, kasi yung iba, yes, sometimes, ha? When you take up the medical boards or the physician's licensure exam, baka hindi nyo na ito mabasa ulit. So ngayon pa lang basahin nyo na, okay? Magpa-pop up na lang yan sa inyo when you take the exam. So, basahin nyo yan. And then, ang sikreto talaga ng pagiging doktor is basahin nyo repeat. For example, diabetes mellitus. Basahin nyo yan 5 times, 10 times. Mamamaster nyo. Okay? Okay ba? Okay ba yung tip ko?
Yes, Doc.
Okay, so bye-bye and see you next time.
Thank you, Doc.
Thank you,
Doc.
Thank you, Doc. Okay, bye. See you.
Doc, Merry Christmas.
Merry Christmas. We will still meet before Christmas. Okay, bye.
Thank you,
Bye,
Doc.
Bye-bye.